allow me to be here to fill you in on some knowledge. Hopefully that by this presentation, somebody will be informed. So I'll just ask if it's something is pressing on your heart, you can use the raise hand icon, but we can answer questions at the end as well too. So let's get started. Hey. So may we home the screen? Do you guys see my screen?
Yes.
All right, cool. Do you guys see everything?
Yep.
Perfect. All right. So the presentation talk today will be gynecological emergencies. It will be presented by me, Kenneth Kwame Sarpong. So disclosures before we talk. I have no disclosures or conflict of interest. If you have any personal medical problems, please follow up with your primary care doctor or your OB-GYN physician. I can answer mostly general questions. So the first thing we'll be talking about is miscarriages. So I'll make this a little bit interactive. So miscarriage. What can somebody explain to me what a miscarriage is? Just one person.
Someone who is pregnant and in the course of their pregnancy, they lose their baby or they lose the fetus.
Okay, all right. So there's actually a misconception. So yes, a miscarriage is somebody who loses their baby, but it's at a specific time. So a miscarriage is a spontaneous abortion. So yes, somebody who is pregnant, but the fetus is aborted. So it's actually early pregnancy loss. So classification between miscarriage and stillborn, it has to be under 20 weeks. So usually 10 to 14% of people will experience some sort of miscarriage in their pregnancy. And then 33% of women throughout their reproductive years. So that'll be 1 out of 3 women will experience some sort of miscarriage during their lifetime before they hit menopause. So why do people get miscarriages? So the reason is due to chromosome issues. So the father has genes, the mother has genes. If they come together and there's some problems in those chromosomes, nature will allow you to have that miscarriage because some of these chromosomes, like on chromosome 21, if there's a problem with that, a lot of those kids have Down syndrome. So a lot of times nature will try to make sure that you have a healthy kid. So for the most part, if there's issues with those chromosomes, you will have that miscarriage. Other risk factors is if you're older in age. So they say that geriatric pregnancy is above 35. So as you get older, higher chance of getting a miscarriage. If you've had miscarriages in the past, you have a higher chance of getting miscarriage in the future. If you drink alcohol, diabetic, thyroid issues, if you're overweight or if you're underweight, if you smoke or if you drink a lot of caffeine. So what are the symptoms of a miscarriage? Vaginal bleeding. You could get spotting to profuse bleeding. Also abdominal cramping as well too. So we're going to talk about the classifications of a miscarriage. So this is a brief overview. So first classification, we have what we call threatened miscarriage or threatened abortion. So I see this a lot in the emergency department. Doc, I'm 12 weeks pregnant, but I'm getting this spotting or bleeding. So when we say threatened miscarriage, that means that the cervix is closed. So when I go into the bedside, I put the ultrasound, I can see your heartbeat. So if it's 146, 150, 170, okay, there's a chance the pregnancy can go through. We have the next classification is called inevitable abortion. So that means the cervical os is open. So when somebody is delivering, the cervical os starts to widen because it wants the fetus to come out. So this means that the fetus is going to eventually come out. So with this, sometimes you see a heartbeat, sometimes you don't. Incomplete abortion or miscarriage means the cervical os is open. When you're on the toilet, you see some of the fetal products, but not all of the fetus has passed through. The last one is what we call complete abortion. So basically the cervical os is closed and all the fetus products of conception have passed. So like we talked about, if somebody comes and they think they're having a miscarriage, how do I evaluate the person? First, I'll do a bedside ultrasound. I'm going to see, hey, is there a heart beating? Do I see a head? Is the baby moving spontaneously? Other things I'll do is get a pregnancy hormone level. I'll get blood work to see if their hemoglobin is high or low. I'll get urine. Sometimes if you have a urinary tract infection, that can cause your vaginal bleeding as well too. And so the best way to find out what's going on in pregnancy is transvaginal. So I will do transabdominal. I'll put the ultrasound on your belly, but we have to call in the ultrasound tech. They'll get the probe and put it in your vagina. That will be able to really look at the fetus during pregnancy. So how do we manage somebody who's going through a miscarriage? So most of the time, the OB/GYN doctor will be like, let's do what we call wait and watch approach. So you're having vaginal bleeding. I may see the baby. Let's wait. Maybe the pregnancy will go through. Other times, we'll just wait, and some women will just allow the fetal products of conception to go. So usually by 8 weeks, 80% of women will complete the miscarriage. A next step is some women will be like, hey, doc, I don't want to wait 8 weeks. I want this thing to, hurry up and get it over with. So we have two medications. So we have misoprostol and mifepristone. So misoprostol, that'll cause the uterus to contract and it'll push the fetus out. So 71% of women by day 3 after taking this medication, the fetus will be out. And if you give a second dose, 84% of women, the fetus will be out and the miscarriage will be complete. Another medication is mifepristone. So that kind of blocks the uterine lining so that it works with the misoprostol to get the fetus out. And usually this has an 84% success rate if you use them together. Sorry. So if the medical management, you take the medications and it doesn't work, what else can you do? So the last step would be called surgical evacuation. So we usually only reserve this for patients, they're bleeding so much, their blood levels are low, their blood pressure is low. If there's signs of infection, or if the mom says, doc, I just want to get this over with, they'll go to the surgical approach. So we have two things. We have what we call the manual vacuum aspiration. I can do this. I choose not to do this. I'll let the big dogs, the specialists deal with this. But what we do is basically put a vacuum in the vagina and then use a vacuum and you suck the fetus out. The next one is what we call a D&C, dilatation curettage. They put a speculum, open up the vagina, and they put a vacuum and it'll just bring the fetus out. So notes after miscarriage. So what they recommend is that 1 to 2 weeks after you have a miscarriage, refrain from having sex so you don't get an infection. But there is a misconception after miscarriage, should I wait a year? Should I wait 6 months? Studies show if you wait 3 months or less or 3 months or more, there's no change in the outcome of you having a successful pregnancy. So after your first miscarriage, you don't necessarily need to do a follow-up. But if you keep having multiple miscarriages, it is recommended to follow up with OB/GYN. Maybe you have a blood clot issue. Maybe there's something in your uterus preventing you from having a successful pregnancy. Studies also show that vitamins, bed rest is not going to stop a miscarriage from happening. Does anybody have any questions? All right. We'll go to the next slide. So the next thing we'll talk about is what we call abnormal uterine bleeding. It used to be called dysfunctional uterine bleeding, but ACOG changed the name. So this is a very common complaint I see in the ages about 20 to 40 years old. So abnormal uterine bleeding, there's a very wide range. So basically, somebody can say, doc, I'm having heavy periods. I'm bleeding so much. Every hour I'm changing my pads. Or doc, it's not my period, but I'm having bleeding. What's going on? So 14% of women are going to experience some sort of abnormal uterine bleeding before menopause. So how do these people present? So usually menstruation cycle average is about 5 days. So some people have it in 4, some people have it in 7. If you have bleeding more than 7 days, that's abnormal uterine bleeding. If you have more than 80 milliliters of blood that's abnormal uterine bleeding. I put this cup on the screen. It's about 30 milliliters. So if you get about 2 or more, that's abnormal. If you're changing your pad every 3 hours, that's abnormal. Or if you have blood clots that are more than an inch, those also abnormal. The causes of abnormal uterine bleeding, we have what we call Palm-Cohen. So the first thing is if you have polyps in your uterus, that can cause this. If you have fibroids, we're going to talk about that later, that can cause bleeding. If you have cancer, that can cause the bleeding as well too. If you have issues of bleeding disorders in your family, that can cause this. If you have kind of weird menstrual cycles, that can cause this. Iatrogenic, if you just got a surgical, if you got a procedure, you went to your OB-GYN, they did a procedure, that can cause it. Rough sex can cause it as well too. So what I'll do if I see people who complain, doc, I'm having abnormal uterine bleeding, first I'll check your pregnancy level. If your pregnancy hormone is high, you're probably bleeding because you're pregnant. Other things as well too, I'll get a CBC, that'll check your hemoglobin to see, make sure, do you need a blood transfusion if the bleeding is so bad that you need some sort of transfusion. Other things as well, I get an STD panels if you got chlamydia, gonorrhea, that can cause bleeding. The last thing, we'll also get a pelvic ultrasound to see what's going on inside to cause the bleeding. So management. So first, management is if you have mild bleeding, I'll give you naproxen, so ibuprofen, Motrin. So the way it works is those medications, they're called NSAIDs. They block what we call prostaglandin. So if something is bleeding, it's going to cause the blood vessel to constrict and stop the bleeding. And if you're anemic, I'll give you some iron supplements. I usually use the second strategy, which is giving birth control. So I'll give progesterone. I give you a week's supply. You'll take it 3 times a day. And then you follow up with OB-GYN. And a lot of women have found success in this method as well too. Next thing, if it's so bad, so usually normal blood levels for women, 11 or 12. If it's under 7, you need blood transfusion. So last week I had a lady, doc, I'm dizzy, I keep passing out, I'm bleeding. Her hemoglobin was 5. So I had to give her some blood transfusion. Other things as well, we can give what we call TXA. It helps block bleeding. And then we can do intravaginal packing. We'll just pack the uterus with material to stop the bleeding from being profuse. The last resort, if you're bleeding for so much, it's horrible, they can't control it. There's many methods surgically they can do. They can do what we call a hysterectomy. So they take the uterus completely. That's the last result. If you're trying to have kids, this is not the method for you. We have the DNC, what we talked about. We use the vacuum. Sometimes they could suck some material if it's bleeding out and boom, they stop it. And then another thing is what we call uterine artery embolization. So basically the uterine artery, if it's bleeding, they'll use material to burn it and that will stop the bleeding. However, the artery is supplying blood to the uterus. So if there's no blood supply, your uterus is dead. Therefore, you can't have kids. So these are kind of last strategies for people to get their bleeding controlled. Next topic we'll talk about are fibroids. We call it leiomyoma. So what are fibroids? Can anybody tell me what fibroids is without looking at the screen? That'll be kind of hard, but we'll go back. What is a fibroid? Crickets. Okay. All right. So a fibroid is the most non-cancerous tumor in females. So you have the uterus. You see it on my right side. The inside is called the endometrium. That's when you have your period. Those cells, it sheds out. You have the myometrium. That's the middle part. And then you have the perimetrium. That's the outer part. So usually the fibroids happens in the middle part. So usually if you can have kids, you have a higher chance of getting a fibroid. So by age 50, white women, about 70% of them will get a fibroid. Black women, 80% by the age of 50 will get a fibroid. I found studies that showed Ghanaian women between the ages of 35 and 39 are the highest chances you are probably going to get a fibroid. So who's at risk? If you have a period before the age of 12, higher chance you will get a fibroid. If you've never had kids ever in your life, higher chance you're going to get a fibroid. If you're taking birth control and it has estrogen in it, higher chance of getting a fibroid. And if you're obese, higher chance of getting a fibroid. Why? Because obesity, a lot of fat cells have a lot of estrogen, hence why people get fibroids. So what would this person who has a fibroid, how would they present to me? So basically, doc, I'm having vaginal bleeding. My pelvis hurts. When I have sex, it hurts. Doc, when I pee, it just comes by itself. Or doc, when I pee, I can't get everything out. Super constipated. Or I'm trying to have kids and I can't have kids. So what do I do when somebody comes in with these complaints? Like we talked about before, I get pregnancy hormone, I check your blood levels, I'll get an ultrasound. The ultrasound will help me see where the fibroid is, and then I could get a CAT scan or MRI. This is usually used later on if they want to do surgery to cut out the fibroid. So how do I manage it? Like we talked about, NSAIDs that help stops the bleeding. If your blood levels is low, I'll give you some fluid or blood. Other things, birth control, or sometimes just kind of watching and waiting, kind of managing your symptoms to see if it gets better or worse. Next steps, if the fibroids is really getting bad, we'll do what we call hysteroscopy. So basically, I'll put a scope, the OB-GYN will put a scope, and they'll put the camera down in your vagina, and sometimes they can go take out the fibroid and pull it out. In China, they use what we call high intense focus ultrasound. They use ultrasound shock waves, and basically they burn or shrink the fibroid. We have what we call myomectomy. So basically they'll go do surgery and just cut the fibroid out so we can preserve the uterus so you could still have kids. And if it's that bad, we'll take out the whole uterus. We call that a hysterectomy. The only problem with hysterectomy, people get mood swings, people get menopause early, people start to get other cardiac problems and psych problems. So we try to avoid hysterectomy as much as possible. Last topic we're going to talk about is what we call endometriosis. So endometriosis is basically, we talked about the endometrium, that lining when you have a period, it sheds out. Those tissues are found outside of the uterus. So it could be on the ovary, your lungs, your stomach. So about 80% of most endometriosis is found in the ovary, like you see on the left and right side. So who's at risk? So if you have genetic problems, high predisposition to endometriosis, you'll get it. If your mom had it, grandma had it, most likely. If you've never had kids, higher chances. Like we talked about, if you had a menstruation cycle early, age 9, 11, higher chance. If it's taken a while for you to get to menopause, high chance of endometriosis. If you're underweight, high chance of endometriosis. And the taller you are, higher chance of endometriosis. So how does endometriosis present as? First one I see a lot is pelvic pain, my stomach hurts. You're trying to have kids, you're unsuccessful, painful vaginal bleeding. When you poop, it hurts, or when you have sex, it hurts. So the gold standard is actually laparoscopy. So basically, they'll take you into the surgery room, they'll put some cameras in your belly, and they'll do an investigation in your pelvis. These scarring dark spots are what we call the endometriosis right here. You see it's by the ureter, the rectum, the uterus. All these are scarring tissue with the endometriosis. So we talk about medical management. So basically you give them pain medicine, diet. If you eat more greeny leafy vegetables, decreases your chance of endometriosis. But if you eat more red meat, higher chance of endometriosis. Sometimes they have some pelvic floor exercises that can help as well too. So basically in a nutshell, if all of this doesn't work, like we talked about, hysterectomy. As you see, lady before has a uterus, lady after no uterus. So sometimes they can cut the endometriosis out But when they cut it out, the chances of you going back to having to get another procedure is about 50%. And sometimes they could take the ovaries out. That can help as well too. With that being said, thank you for listening to my presentation. Any questions? We will open the floor.
Thank you very much, Dr. Sapon. Thank you. Okay, Sedia Kenika, the floor is open for questions. See,
Hi, Doctor. Good evening, Pastor Antitinani. So what about the RH type of blood grouping? Because I know that if you're pregnant and you're RH positive and the baby is negative, that can also cause a miscarriage.
So,
and
yeah,
how do you treat it?
So you are right. So basically, if you have RH negative blood type, what happens during your first miscarriage is nothing. So then your body will start making antibodies. So if you have a second pregnancy and your baby is RH negative, basically those antibodies will go in and, oh, this baby is foreign to us. It will kill the baby. So what we do is we give a medication called Rogam. So any woman that is RH negative, we will give you Rogam after the pregnancy so that when you have future pregnancies, your body won't kill the next baby. But if you're RH positive, we don't do nothing. I hope that answers the question.
Thank you, Doc.
No problem.
Okay, so I have a follow-up question on the RH. What is RH for those of us that doesn't know?
So it's a blood type. So it has, people have A blood type, B blood type, O blood type. The RH factor, you have A negative, A positive. So it's just a classification of everybody's blood type. Everybody is different. So like Auntie Tina was asking, if you have RH negative, we have to be a little bit more careful because if you have a miscarriage, that negative will cause antibodies to kill your future pregnancies if we don't give you medicine to stop those antibodies from flaring up in your body during future pregnancies.
Thank you.
Hi, Kenneth. You mentioned that taking out the uterus was basically the last step. What are some of the side effects of that? Because I know you did mention mood swings and early menopause, but what are some of the other side effects that somebody can experience if their uterus is taken out, if they have a hysterectomy?
So like when I did research, just a lot of women can attest early menopause, hot flashes, mood swings, more depressed, moods very labile, cardiovascular disease, like hypertension, heart attacks, things like strokes. So, this is the reason why God made women so beautifully to give uterus to generate hormones to kind of protect themselves. So if at a young age or outside of this, age group above 50 and you have this early hysterectomy, it kind of predisposes you at an early age to some of these diseases. That makes sense.
Yes, and what are some of the things that the doctors do to prepare you for what you're about to go through?
So in regards to, I can't really speak on OB-GYN what happens after specifically, but from historically when I was on my OB-GYN rotation, things like that. For example, like, estrogen causes lubrication in your vagina, it causes you to be, sexually aroused. Other things like it helps with bone development as well too. So if this is an issue, they're going to make you get on calcium pills, hormonal therapy like estrogen supplements so you can still have a good sex life. You could still have good bones and things like that so you could do your daily living. Sometimes they may put you on some, antidepressive medications as well too, things like that. But OB-GYN will probably have those kind of answers, but from my knowledge, those are the things that you would get. And remember, old lady, higher chance when she falls, she's going to break her bone. That's why it's good to have estrogen and the uterus. So, you got to understand those are the risk factors when we do take out your uterus if you get a hysterectomy at the age of 30 or 20.
Doc, I have 2 more questions, please.
Okay.
So Rogam no. If you are RH negative, na say u second the first pregnancy no unya miscarriage. Na say unya same biwa, they will give you the Rogam. So
Correct, yes.
will it be given to you after with every pregnancy or just the one, the second or the first after your miscarriage?
Every pregnancy.
Every pregnancy, okay.
In my practice, if you're RH negative and you miscarry, or even if you have vaginal bleeding. So for me, is if you have vaginal bleeding and you're pregnant, RH negative, I'm giving you Rogam. So they have classifications. We give a dose if basically like you're under like 10 weeks, and if you're above, we give you a higher dosage. But every pregnancy, if you have bleeding, miscarriage, I'm giving you Rogam.
Okay, sorry. My second question, you know.
Mm-hmm.
So after hysterectomy, people can get hot flashes. Mostly at menopause, we get those hot flashes. So hot flashes, you know, now the estrogen in it treated before, but then it came out that estrogen has so much side effects and it could even cause cancer. So are we still using estrogen to treat, or how can we treat it without the estrogen?
So to be honest, I can't really kind of comment on that. This is just from my kind of peripheral, view from OB-GYN when I talk to them. Yeah, so remember estrogen, endometrial cancer, ovarian cancer, those tumor cells love estrogen. Breast cancer, they love estrogen. So I'm not too sure the guidelines right now on dealing with women with menopause, with estrogen therapy. But as I know, for the most part, though, to kind of help with these symptoms, that's kind of the first go-to. But I think speaking with your OB-GYN, you'll kind of make that decision together. The thing I did forget to say as well, too, is remember, sometimes hysterectomy, you can preserve the ovaries. The ovaries do produce estrogen as well, too. So not necessarily every time you take out the uterus, you have to be on estrogen supplementation. It's only when they do a salpingo oophorectomy, meaning they take the uterus and ovaries, they may have to consider giving you estrogen therapy. Somebody asked, so if your condition can be managed without having a hysterectomy, don't have to be done. Yes, it's the last option. It's like you've tried everything and it didn't work. That's the last thing any OB-GYN wants to do is take out your uterus. Auntie Tina, I hope I answered your question.
Yeah, you did. Thank you so much.
No problem.
So, Dr. Kenneth, I want to ask a question. I have somebody who had a child for about 7 years, then she got pregnant, and then she had ectopic. And then after that, I think almost a year, she got pregnant again, but she had a miscarriage. Research what causes that, and is there anything to be done on her part? I don't know. She is a new kiddo.
So great question. So let me see, so obi or ectopic pregnancy. Anybody could tell me what an ectopic pregnancy is? Obi betimia trechemu ectopic pregnancy.
She had an ectopic, right? And then after that, within a year, exactly a year, she had a miscarriage.
I understand the question, Miss Sit. If somebody in the chat.
No, I knew somebody. She had a child already, right? But the child was 7 years.
I'm going to answer the question. I'm just trying to see if we're saying a lot of these lingo. Perfect. Or say pregnancy outside the womb. So ectopic pregnancy basically means we have the ovaries, fallopian tube, uterus. So usually when the egg comes out, it falls down into the uterus, the sperm comes, and you have the baby grow in the uterus. So if the egg and the pregnancy happens in the fallopian tube somewhere else, we call that ectopic pregnancy. So the problem is basically sometimes when we have ectopic pregnancies, it causes scarring in that fallopian tube or that area. So when that scarring, after they do surgery, take out that ectopic pregnancy, It's harder for you to have conception, therefore higher chance of miscarriage.
Okay.
Yeah.
So that's why she had a miscarriage then. Is there anything she can do?
There's nothing, either you could try again or you can do IVF, in vitro fertilization, where they take the egg, they put the sperm
Okay.
together and they directly put it into your uterus, or you get a surrogate. That's another strategy.
Oh, okay. Thank you.
No problem. Somebody asked, with RH negative and RH positive father, yes, that can help as well too. But remember, it's still 50-50, but yes, it can happen that the RH positive dad can help and that the baby will be fine.
Kenneth, your fibroid statistics that you were giving, you said Ghanaian women between the age of 35 to 39 had the highest chance of getting high fibroids?
Those are the highest incidence of fibroids, correct? Yeah.
Okay. And why? What's happened? Why is it that
I have
age?
no clue. I'm trying to look at the paper. I didn't really get a chance to dive deep into the paper. But it's on my tab. I'll try to forward you the paper and get some answers about it. But it was just they did a data analysis, and basically they found that for Ghanaian women specifically, that age
Yeah.
group has the highest chances of fibroids. I have no clue why though.
Okay. It would be great to know because, some of us are in that age group.
Hi, doctor. Sorry, you did say that the earlier you have your period, there's a higher chance for you to get fibroid as well, right?
Right.
How is there anything? I know that our environment and the diet that we have also contributes to earlier menstruation. Is there anything that we can do to delay that?
That, I mean, sometimes it's genetic. Like, I know a lot of women like, oh, my mom had her period early. I had her period early too, as well too. So that could be a factor as well too. Yes, environmental factors as well. Kind of the diet you eat, fatty foods, like, junk food, things like that can probably contribute to that. But also, a lot of those things is mostly genetic, to be honest. But I haven't seen anything that, like, hey, my kid is 8 or 9, like, let me give them this certain food or this and that to stop them from having a period, But that would be my answer for the moment right now. But I haven't found anything to prevent somebody from getting a period at the age of 9 or 10 yet.
That's kind of nature's way.
Yeah.
Okay, doctor, can I ask one more question?
No problem.
Said when somebody is pregnant, right? Somebody who alleged to having miscarriages, being in bed cannot stop or cannot help. But I know somebody when she gets pregnant, the doctor keep her in the hospital in bed till she delivers, and she's able to deliver. She had it 2 times. So what about that, and how? Or is there anything done?
But how many weeks though? Because usually when
I never asked, but I only know 2 times she had it, and she has to be protected. They have to be in bed at the hospital till she delivers.
Kind of bed rest.
So I mean, if you think about it, pregnancy is about theoretically 40 weeks, right? So it would be impossible to keep somebody in the hospital for 40 weeks. But I know if somebody has higher chances of miscarriages, stillbirths, things like that, sometimes doctors in the 3rd trimester, 32 weeks, 35 weeks, things like that, they may recommend bed rest. I haven't seen any studies that shows it changes the outcome. But I know, like we said, miscarriages before 20 weeks, a doctor most likely, I've never seen a doctor keep a patient in for 20 weeks to help the pregnancy progress, from my knowledge. I usually find that they do it the later trimesters, if there's like issues during the pregnancies, bed rest, and they'll go like, do an elective, delivery, things like that. But the earlier part, I don't know if bed rest will really stop or do anything because, yeah, that I know of or I've seen during medical school and residency, from my knowledge.
I don't know, but the one I'm talking about, she be in the hospital for maybe over 5 months or so before the baby comes out, and then they allow her to go home. So that's why I'm asking about it.
Yeah, I mean, 5 months, that's a little bit early, but it's reasonable, I guess. But, like I said, everybody is different. So, maybe she had some certain circumstances, genetic issues that will cause her to require to go bed rest early. But for the most part, if you take 100 women, staying at home or resting won't stop you from getting the miscarriage.
Okay. Thank you so much.
No problem.
Okay, doctor, I have a question. So, two questions. So, one, no, actually, I think it's one question. So, relating to fibroid. So, I don't know if it's misconception or it's true. So, this is what I heard, that it skips generation. So, let's say my mom has it. I don't get it, but unfortunately, my daughter is going to have it. Is it true or it's a misconception?
That's a misconception. There's no study that's showing that it skips generations. Every other female in the bloodline will get it. If your mom got it, higher chance you may get it, you may not get it. For example, like my dad, he has predisposition to get kidney stones. I've never had a kidney stone, knock on wood. So, some people get it, some people don't. Because remember, in regards to genes, you have your dad's genes and mom's genes. So when it mixes, sometimes the odds, it's in their favor not to get it. Sometimes the dad brings that fibroid genes or whatever with yours, and then it increases the chance of, well.
Okay, thank you.
No problem.
Is it genetic? Like, what's the percentage of you getting it from?
So I wouldn't say genetic, like, oh, if your mom has fibroids, you have a 90% chance of getting fibroids. You just have a higher chance. The stats, I have no clue. But like I said too, remember, if you're obese, if you take birth control with estrogen, if your family has it, those increases your chances of getting fibroids compared to other people. If you've never had kids, if you're 35, you've never had a kid in your life, higher chance of getting a fibroid. So. Hello?
Okay, so back to the fibroid. So I've seen that some women that has it are not able to conceive, and some are. Is there a reason why?
So remember, if we go back, hold on, let me try to share my screen. So remember, like we talked about, right? With the fibroid, so it's a tumor growth. So if the fibroid is here hanging in the uterus and it's blocking the kid from coming out or from the sperm from meeting the egg, yes. Or if it's pushing in the uterus, it's not even allowing the places to grow, yes. But if it's outside, like the one at the top, or outside somewhere else, that fibroid won't really mess with the area of conception, if that makes sense.
Okay.
Yeah.
Okay, thank you.
Yeah, Kenny, so okay for a tumor, a fibroid, no? Is it a malignant or benign tumor? So a bit me a cancerous, so where in here? A bit me done cancerous.
There be a non-cancerous, non-malignant intiminia cancer to kill you, but it's annoying. But other than that, it does not develop into cancer where it will travel to your heart, lungs, brains, colon. Fibroid is not that type of cancer. Things like ovarian cancer, cervical cancer, endometrial cancer, those are the ones that will cause worsening cancers or malignancies or problems that can kill you in the future. But fibroids is not one of them.
Thank you.
Okay, so there's a question in the chat.
Yes. So as stated before, eating a healthy diet, green leafy vegetables, decreasing, raw meat, things like that. I haven't seen the one on vitamin D, on decreasing fibroids, but I'll kind of look into that. But, a lot of these diseases, managing your weight, sleeping well, following up with your OB-GYN, things like that, exercising. These are some of the strategies that can kind of help prevent some of these issues, but some of them like endometriosis, there's no way to really, stop endometriosis. Either you're going to get it or you don't. But yeah.
I have a question. What about if your mom doesn't have a fibroid, but one of your siblings has it? Must it those of the family have that chances to have it too?
Pardon me, say that again. You're saying if your
mom
sibling,
doesn't have fibroid, but one of your siblings, your sister, has it.
Mhm.
So is it something is in the family or it's not?
if your mom didn't get it, another sibling got it,
Mm-hmm.
most likely there's a genetic factor. But genes is very complex. It's not black and white where you have cancer, you have high blood pressure, you have this. Remember, to get certain diseases, you have genes, you have environment, you have so many different things that cause diseases. So the thing is that if your mom didn't have it, maybe she had the gene to get fibroids, but she didn't express it. Maybe she was underweight. Maybe she, had a good diet. Other times, and especially if you have more kids, the gene pool, it's all random. So maybe you didn't get it, somebody else got it. So it's all random. But if one of your siblings has it, that means most of you guys may have the genes as well to get fibroids and can pass it down to your kids. But like I said, there's other factors, weight, diet, sleep. Those things can also affect it as well too. So it's not just a cut and paste, black and white. You have it, your daughter's gonna have it, your grandchild is gonna have it. No, there's so many factors that can predispose you to getting the fibroid, if that makes sense.
Thank you.
No problem.
Please, if I may ask, you talk about weight, right? So, can older women who are obese have this fibroid?
Yes.
Older women, maybe in their old age, about 60 plus and so on, and have weight problem?
So I mean, if you're in menopause and obese, it might counteract. But if you're still having periods and you're obese as well too, it increases your chances.
It's only when you still have a period, right?
Yeah, if you still having your period and you're
Only
obese
when
as
you
well.
still have a period. Oh, okay.
Yeah, it increases your chances.
Hi, Kenny.
Okay.
Hey, what's up?
And the Women's Ministry Department. I came on a bit late. Did we talk about only fibroids, or was there something else that was discussed? Because I'm thinking, is it fibroids that we only talked about in this presentation today, or was that I came in late? That's why I'm asking. Because that's why I'm asking.
Oh, no, so we talked about a couple of things. We talked about miscarriages.
Okay.
We talked about fibroids, and we talked about endometriosis.
Okay, because one thing I hope someday maybe you can come back and discuss with us is polycystic ovarian syndrome.
Oh, PCOS.
Yeah, PCOS. I think it's something that would be great if it could be talked about in length. I think it's more common than we think, and so I think it would be great. I thought maybe it was part of the discussion, but I think it'd be great if someday we can invite you again to have a little discussion about that as well. But yeah, thank you.
No worries. Yes, next time. I know somebody posed a question about cervical cancer. There's many things that could cause cancer, but that is not the talk today. I know PCOS as well too. That's a very common thing, causes diabetes, people to have facial hair, things like that.
Right.
We could talk about that. I think what we need to do is let Sister May send your requests to her, and she will relay it to me, and then we'll go from there in the future.
Yeah, sounds good. Thank you.
Doc, so time also there. But
Yes, 7 minutes. But
is is there a time in the age of a woman who expect you wouldn't be getting fibroids now? Yeah, kind of crying. So we'll say, for example, for Ghanaian women from about 35 to 39, and so started giving the age group so is there a period of your time where then you can go scot-free, you wouldn't be getting it?
I mean, personally, I haven't seen statistics like, 70 up, 0 fibroids, or like 21 under. I haven't seen that, but theoretically, once you hit that menopause age, remember fibroids, they love estrogen. If there's no estrogen to feed that fibroid, then the chances of you getting fibroids are lower. Not saying it's impossible, but it's lower. That makes sense.
Great. Thank you.
Me yente wo kasa no.
You're muted.
Sorry, I was muted. Sorry. Okay, so last question. Okay, so what's the difference between ovarian cysts and fibroid?
So remember, ovarian cysts. Oh, that was one I should have really harped on too as well too. So remember, cyst is fluid filled. It means nothing. So you can have a cyst in your kidney, cyst in your ovary, cyst anywhere. So a cyst, it just means there's fluid in it. So the thing is that I've seen in the ED a lot, doc, I'm having vaginal bleeding. My pelvis hurts. And you'll see, you have a 3-centimeter cyst. Sometimes during your period, that cyst, it gets big. When you're outside of your period, it gets small. For me as an emergency medicine doctor, my job is to rule out any super scary things. So when the cyst is above 5 centimeters, it can cause your ovary to twist on itself and kill the ovary because there's no blood flow. So a fibroid is non-cancerous non-cancerous. So it's made up of like muscle cells. That's what a fibroid is, muscle cells and fibroblasts. The cyst is just fluid, water, and it shrinks and gets bigger. That makes sense.
Okay, so there's no immediate danger with cysts.
So cyst, there's no immediate danger. So for the most part, if it's a 1-centimeter cyst, 2-centimeter cyst, and you can take pain medication, it's okay. When it gets 5 centimeters, that's when I'll call OBGYN, hey, this is 5 centimeters, high risk of ovarian torsion. Usually what they will do is they'll probably take the patient to the operating room and go remove the cyst so it doesn't become a problem in the future. Other things with ovarian cysts, sometimes it can rupture. Either it could just burst and you'll just see free fluid in the pelvis and your body reabsorb it and you go about your life. But I've seen some people, they have cysts, it doesn't bother them. Some people, they have cysts and it hurts them so bad. So like I said, cysts are fluid filled. Fibroid is muscle cells and fibroblast that grows. Those are the two differences. And usually fibroids, I don't see them in the ovaries. Usually cysts, I see them in the ovaries. So usually the fibroid, you find them in the uterus. The cysts, you'll find them in the ovaries.
Okay, so we are out of time and our doctor have to go to work. So we're going to wrap it up. So thank you, Dr. Kenny. Thank you very much for accepting to do this program for us. On behalf of the Women Ministry, we say thank you and God bless you. And this is not the first. We definitely invite you over in the new year. So just so you know. Okay, so sorry, me patrobi kabibi. Okay, I think so. Okay. Enti yebema Sister Ekria, Gertrude. Me pacho mpaye emfa mpon ye na mia se wama Kenny the knowledge say obetimi esua de na and wamana yes wamana aye what's the word watimi amana be mo ne ono so timi amana ye nsura ama ye nyina amane we timi esua bibi na sure no na fanish nyamensa adwuma wokọ se nyamenfa no koduru asumdwem no fani ba asumdwe na do be ye bia no onye hye ne din no manyam na ya yekoda so se fanish nyamensa timi so my closing prayer na yempo step ya
No, mama, my mom pay. Australia, I see a phone and then me, mother was saying, Mary. Yet I was a baby, so what can you do? No, now what you can read when I'm not them no homo bros, so there be dear shame more. They want them no homo bro in a year, sir. I said, I called Dean, and was side, you may dear when I'm not them so ama and then saka. The doing no, yet I was sick. So, Dean, I be shy. In himself, when I'm a course so. When I'm Kenny so upwine amayati and some more addition to say a big wine, ye my and normal echo so ever any pedriamo. Send a bear you bit to me a phrase so ye. Then put a bar prayer to me so upwine. Any even treatment and so I will say it in 200 more bianso no. Yet that was a sewer be sa quine or amaye. Yet that was a beer moon in dear old day ama Kenny. Nay. Ni school komu nyina wadom no homo pra wo de aka no ho ne de nso wabeye mfaso de de ama asafo yi nhira ayeye ne nkamfo enkaudi e wosa kwan ne so yekoso de na hye wonsa isa se adwuma nipa ho adwuma na woye nti da yeso ne se wobekoso na wabo na ho ban na de be mu so ne sign mistake bi ebeba e wona brabom ne na adwuma yi bi emu ne rade wapani nyina egu na wama no adwene a imuda ho no hosuro ensusu ewoni mu se ne be ya sa onye sa mistake bi de o how be bre no ni future obekoso na wahira no na empo ebra wahwere ewe ye ho ne adesua de ama yeso wona modom so na waka no ho na ne koma so ebisade bi eda na koma so so wurade waje ama no ebi mo wona modom so de adesua te sa ama yeso se wurade kaya ho na yintu ho na mo ama yinti ne keke Nemo yentumi so spread it fama yen yanomo so a okaye ho na wentumi amala iso enti do me so say ye bede dai ni ho so hwe etu nyina ye ho ahye won saso nkokwa so so se be ho ba anadwu de so yi mo yourself ahyehyɛ afa yi mu piara ho anadwu de so be pani nyina egu ye de ho ne abusua nyina ehye omogya de hye se ti wani mi tren obofo ni efusane anadwu na de be no so ni san wapego ade pe bi chen so a wosiesie no nya na efie na mpaso na wo de akọ in various places enti enyumre ye mpa ebo ni adisre ni esro se kan ho na ni le sama ye e beda wase ni ahye wedin eni monyamo de odi abedru ni shranka odin se waye eni de oba be ya man we yesu de mo